morning. I've got 12 o'clock. Dr. Taylor, the floor is yours.
Thank you. Good morning or good afternoon, everyone, depending on where in the world you are calling from. Thank you for joining us for today's webinar, BRFSS Data for Older Adults Health. I'm Dr. Chris Taylor with the CDC Alzheimer's Disease and Healthy Aging Program in the CDC National Center for Chronic Disease Prevention and Health Promotion. We'll be starting with our 4 wonderful presentations shortly, but first I'm going to turn it over to Michael Jackson, our communications specialist, who will go over some housekeeping issues for today's presentations. Michael?
Thank you, Dr. Taylor. Good morning, everyone. As you can see on the screen, we'll just go over these 4 key points for this morning. Everybody will be on mute for the duration of the presentation, and you'll have an opportunity to ask questions at the conclusion of the presentation. The 2 ways you can ask questions by using the raise the hand feature, which is on the right-hand side of the menu that all of you should be seeing at this time. The other way is you can use the chat feature, which is the last line on the menu on the right-hand side, and that's just a typical chat, just like any other chat. Any specific question you have about the slide that you may think of later, you can email me, and this slide is up, and you can jot my email down, and I'll triage your question and get a response to you. And we have to tell you that the presentation is being recorded. It will be archived, and you will receive notice when it's ready for public viewing. And if you have any colleagues who are having trouble with accessing the software, getting onto the webinar, you can jot that number down. But again, it's a GoToMeeting deal. I can't help them get access with it. You have to contact the software company. So with that, we'll go back to Dr. Taylor and get started. Thank you.
Thank you, Michael. So today's webinar, we will have 4 presenters. Each presenter will describe a data set or tool for data on older adult health using the Behavioral Risk Factor Surveillance System, or BRFSS. Each presenter will present in turn, and once all 4 presentations are over, as Michael mentioned, we will have a question and answer session at the end. So, without further ado, today's first presenter is Dr. Valerie Edwards. She's a health scientist with the Alzheimer's Disease and Healthy Aging Program here at the CDC in Atlanta, Georgia. And Dr. Edwards will provide a background on the Behavioral Risk Factor Surveillance System. Dr. Edwards, the floor is yours.
Thank you, Dr. Taylor. Good afternoon, everyone. I just wanted to give you a brief overview about the Behavioral Risk Factor Surveillance Survey. Michael, can you advance the slide, please? Thank you. These were just I just wanted to give you an overview about the system. The BRFSS, as we call it here, is the largest continuously operated telephone health surveillance system in the world, and it's been in operation since 1984. The BRFSS operates as a partnership between the CDC and state and territorial health departments, which includes 57 state departments, and it includes questions on health status, health risk behaviors such as smoking, diet, exercise, chronic conditions such as diabetes, heart disease, and arthritis. And for many states and territories, the BRFSS is the only source for state-level information on these health risks. Next slide, please. So who participates in the BRFSS? Each year, the BRFSS conducts over 400,000 telephone interviews using random digit dialing to reach the participants. Since 2011, this has included cell phones as well as landlines. All non-institutionalized adults age 18 years or older are eligible to participate. And in addition, each participant's data are weighted by a variety of factors, including age, sex, ethnicity, the the geographic within the state in which the data are collected, marital status, educational level, home ownership, and type of phone. Next slide, please. There are 4 components to the BRFS. First is the core survey, which is used annually by all states and territories. The next type is the optional survey modules, about which we'll be talking today. These are sets of questions that address a single topic, and CDC programs as well as other agencies pose these topics to be included in the annual survey. States can also develop their own questions that are added on to their own survey. And finally, there are special project editions which are added on an as-needed basis, usually with dedicated funding, such as when H1N1 flu virus was going around the U.S. And that concludes my overview. I will send it back to Dr. Taylor.
Thank you, Valerie. Our next presentation will be by me. I'll be presenting on this module. For those of you who joined us late, I'm Dr. Chris Taylor, an epidemiologist with CDC's Alzheimer's Disease and Healthy Aging program here in Atlanta. Can I have the next slide, please, Michael? Thank you. So I'm going to talk about our cognitive decline module. So why is the cognitive decline module important? Well, if you think about factors associated with cognitive decline, if you think about conditions like Alzheimer's or other dementias, it's very hard to measure those. So current estimates of Alzheimer's disease are extrapolations from community-based longitudinal studies, and they're applied to a nationally representative sample. And everyone in that study received a diagnostic evaluation, so it's sure whether or not they have Alzheimer's disease. And because what we know about Alzheimer's right now, cause is unknown, so future projections are based solely on demographic changes. Next slide. So an alternative that we use is what we call subjective cognitive decline, or SCD. So subjective cognitive decline is the self-reported experience of confusion or memory loss that's happening more often or is getting worse during the past 12 months. And I'll be talking about that more later. Next slide. So with SCD, not everyone with this subjective cognitive decline goes on to develop a dementia like Alzheimer's disease, but many do. And so it could be a potential indicator of future burden and the needs that would be required within healthcare systems, for long-term services and supports, and for communities. Next slide. So within this module, we assess subjective cognitive decline. We can determine the prevalence of SCD, as well as areas where SCD may have impacted a person's daily routine or activities based on their responses in the BRFSS. We assess SCD in this module in adults 45 years and older, and this is a 6-question module. The first question of the module is a screener for subjective cognitive decline. And as Valerie had mentioned, it is an optional module, but we've been very fortunate with support from the Alzheimer's Association. It's been administered by 49 states, the District of Columbia, and Puerto Rico for the combined years of 2015 and 2016. Next slide. So now I'm going to go through the questions within the cognitive decline module. So question 1, During the past 12 months, have you experienced confusion or memory loss that is happening more often or is getting worse? This is a yes/no question. If a person, a respondent on BRFSS says yes, they continue in this module for the remaining 5 questions. If they say no, they are exited from the module and they are not classified as someone having subjective cognitive decline. Less than 1% of respondents respond don't know or refused, and generally we do not include those responses in our analyses of this module. Some notes to think about when you're analyzing this. Remember, this is a self-report. This is a person self-reporting that they have experienced confusion or memory loss that's happening more often or is getting worse. Also, because it says happening or more often and getting worse, if someone already is at a level of confusion or memory loss, and so if their memory loss is already, maybe they consider it bad, they might not report this because if there had been no decline in the previous year, they might not consider that a yes response for this question. As well as if they had decline, but the decline was prior to the past 12 months, that might also not be reported. Next question, next slide, please. So for question 2, during the past 12 months, as a result of confusion or memory loss, how often have you given up day-to-day household activities you used to do, such as cooking, cleaning, taking medications, driving, or paying bills? And this is a 5-point response. A respondent can answer always, usually, sometimes, rarely, or never. They could also answer don't know or refuse the question, which was less than 2% of responses for this question. And again, we don't usually include those responses in the analysis of this question. When we do analysis here at CDC, we group these responses always, usually, and sometimes versus rarely and never. And again, some notes here. Again, this applies only to specific change that a respondent attributes to increased confusion or memory loss. And also, this refers to having given up activities. So if a person still performs activities, but maybe performs them in a different way or less frequently, they may not report that as part of this question. Next slide. So for question 3, as a result of confusion or memory loss, how often do you need assistance with these day-to-day activities? Again, this is a 5-point response, always, usually, sometimes, rarely, or never. The don't know or refused responses are less than 1% for this question. And again, we group these as always, usually, and sometimes versus responses of rarely and never. So some notes. So a respondent may not have given up activities, but they may need help with them. And that's what this question is trying to capture, in contrast to question 2, where we ask if they've had to give up activities or how often they've had to give up activities, either always, usually, sometimes, rarely, or never. And remember, this is because the respondent believed they needed assistance because of confusion or memory loss. If they had to change their activities for another reason, or if they attribute their change in activities to other reasons, that would not be captured in their response to this question. Next slide, please. So for question 4, when you need help with these day-to-day activities, how often are you able to get the help that you need? Again, always, usually, sometimes, rarely, or never. And for this question, the don't know or refused responses are less than 0.5% of responses. So very few of those types of responses here as well. And again, we group them always, usually, and sometimes are grouped together versus the rarely and never responses. And so one thing to note is when you're analyzing this data, that only this question is only asked among those who reported always, usually, or sometimes needing assistance in question 3. So that's who we're asking this question of. So if they report always, usually, or sometimes needing assistance, we want to know how often are they able to get that assistance. Next slide, please. So for question 5, During the past 12 months, how often has confusion or memory loss interfered with your ability to work, volunteer, or engage in social activities outside the home? Again, 5-point response: always, usually, sometimes, rarely, or never. Don't know and refused responses, as before, are not generally used in the analyses that we perform here at CDC, and they constitute about less than 2% of responses. And again, grouped as the other previous questions: always, usually, and sometimes, versus rarely or never as a response. And so some notes. Again, this is referring to confusion or memory loss. How often has confusion or memory loss interfered with your ability to work, volunteer, or engage in social activities? Interfered with your ability. So it hasn't stopped the respondent from doing this, but it has interfered with it. So that's something to think about depending on what you're trying to analyze or describe when you use this analysis in a paper. And remember, so this question 5 is for everyone who reported subjective cognitive decline. As a reminder, question 4, the previous question, was a subset of those who needed assistance. So question 5 now goes back to all respondents who are within this module who reported subjective cognitive decline. Next slide. So question 6. Have you or anyone else discussed your confusion or memory loss with a healthcare professional? Yes or no? Less than 1% of respondents reported don't know or refused for this question. And so this question asks if they've discussed it with a healthcare professional. So it also means if a child or a caregiver discussed the respondent's confusion or memory loss with a provider. But again, that would require the respondent to know that someone else had asked about it, and that they are reporting that, because remember, this is all self-report, as all of BRFSS is. Next slide. Something that we find useful to calculate as part of our analyses is what we call functional limitations. So this variable is calculated for those that we categorize as having subjective cognitive decline. And I say calculated variable, it's something that an analyst must create. This is something we create. It's not included in the BRFSS dataset. If you're familiar with the BRFSS dataset, or you become familiar with the BRFSS dataset, which we hope that you will if you're not already, there are already some calculated variables in that dataset that are provided by the wonderful team that manages the BRFSS data here at CDC. This data that I'm talking about, this functional limitations variable, is not part of the already calculated variables. It's something that an analyst would have to create. And so functional limitations are present in a respondent if either they report always, usually, or sometimes having given up day-to-day household activities that we mentioned, such as cooking, cleaning, taking medications, or driving, due to confusion or memory loss. That was question 2 of the module. Or they always, usually, or sometimes report that confusion or memory loss interfered with their ability to work, volunteer, or engage in social activities in the home, which is question 5. So when you're writing your code or doing your statistical analysis, you want to include both of these questions to define functional limitations, and also make sure that you're including those that always, usually, or sometimes report giving up household activities, or always, usually, or sometimes reporting an interfered ability to do work, volunteer, or engage in social activities. Next slide, please. Next slide. So I'm going to talk a little bit about some of the things that we do when we analyze the data, at least for my part here at CDC. So some things to remember. BRFSS, as Valerie had mentioned, is a large survey. And because of that, there are statistical weights that are used for each respondent. And that's based on the ranking criteria that she had mentioned in her presentation. And so this weighted data, these data require the use of specific statistical procedures that account for that weighting. And that weighting affects things like confidence intervals, and you really have to use it to make sure that your estimates are accurate, whether you're using multiple states or whether you're performing data within one specific state. The weighting matters. The procedures that you would use to address the statistical weighting vary by the analytics software that you're using, and these BRFSS data can be analyzed in SAS, Stata, SPSS, or Sudan. Those are the programs. Actually, everyone who's presenting today, each of us analyze the data using a different software package. And I'm sure there are other ones that could analyze the BRFSS data as well. Those are certainly, these four are the ones we use here on our team. And so generally, when you use different statistical software, the point values for an estimate are uniform across the analytic platforms, but often the confidence interval values may differ slightly. Usually less than 5 to 10% would be the difference between maybe a SAS to a Stata to a Sudan estimate. Next slide. So for the states, as Valerie had mentioned, optional modules are only administered by participating states. Not every state administers every question, or not every state administers every module every year, and what's called the version may vary state by state. So some states may only administer an optional module for part of the year. So the final statistical weights are affected, which again might affect confidence intervals. And these are also listed in different, when you do the analysis, you want to make sure that you're using the correct data sets. There are multiple data sets on the BRFSS website, and you want to make sure that you're using the correct one. And here I've provided the website for BRFSS, www.cdc.gov/BRFSS. And if you go to there's a BRFSS questionnaire box, and if you go to a section labeled optional module data by category, that gives the correct version for each state too. So you'll know which state completed the module, and as well as which version of the module. And there's also another, and so that's by module category. So you can look up the subjective decline module and see which states administered that module. Alternatively, if you work in a state health department and you aren't familiar with this, there's also a state by module on that same page where you can look up what state you live in and see which modules were administered for that particular year in your state. So we limit data to the states listed in the table. So occasionally a few random values might have been collected for participants in other states, but generally we only examine those that were administered within the states that are listed within that table. Next slide, please. So with respect to age, we administer the cognitive decline module only to adults 45 years and older. BRFSS, as Valerie had mentioned, is administered to all U.S. adults 18 and older, but we limit the cognitive decline module to adults 45 and older because we feel that's the most efficient. That's really a focus on middle-aged and older adults that would be most affected by cognitive decline. Again, like with the state value, occasionally there's a few random values that may have been collected from participants younger than 45 years of age, but generally we only include those participants 45 years and older. For our analysis, and again, this varies by what your practices might be at the institution you represent or at your state health department, we use the variable for imputed age if there's a missing age response, and we include that in our analyses. And the cognitive decline module, again, is only administered to those 45 and older. So if the data is collected and the imputed age is greater than 45, then we include them in our analyses. And just as of note, because we are interested in older adults, I'll point this out, age values for those 80 years and older are limited to protect the confidentiality of those respondents. So in other words, if a person reported being older than 80 years, like they reported their age was 85, in the data set, they would be assigned age 80 to protect confidentiality. So there is no age values in the data set greater than 80. Next slide. And then race and ethnicity. So there is a calculated race and ethnicity included as part of the BRFSS data sets that are available on the website, cdc.gov/BRFSS. And that variable is _race. That's the variable that I usually use. And there's other calculated race and ethnicity variables depending on what your statistical or your analytic needs might be. And this is usually what I do because here at CDC we look at data across multiple states. Often we have a nationwide lens that we look through, in addition to some state-specific analyses. So the categories in the race, this calculated race variable, are non-Hispanic whites and non-Hispanic blacks, non-Hispanic American Indian or Alaska Natives, non-Hispanic Asians, non-Hispanic Native Hawaiians or other Pacific Islanders, non-Hispanic persons of other races, non-Hispanic persons who are multiracial or report multiple races, Hispanics of any race, and people who report don't know, not sure, or refuse, which is less than 2% of all respondents. Next slide. So, could you go back one, please? So for the analysis that I do, if we combine multiple states, we'll often combine non-Hispanic American Indian or Alaska Natives. Oh, I'm sorry. Actually, can you go to the next slide, please, Michael? We'll combine non-Hispanic Asians and non-Hispanic Native Hawaiians or other Pacific Islanders together. And we'll also combine non-Hispanic persons of other race with non-Hispanic multiracial persons. My highlights are wrong on that one. So it's non-Hispanic Asians and non-Hispanic Native Hawaiians or Pacific Islanders that we'll combine, and we'll also combine persons of other race with persons that report multiple races. So in summary, for my part of the talk, if you have never used BRFSS before, if you're not familiar with this module, please refer to BRFSS documentation. There's a lot of great documentation at cdc.gov/BRFSS, and that will really help you. But I also would encourage you to, if you're interested in using these data for your state, to contact me about the cognitive decline module. It's important to remember to use the appropriate statistical procedures that account for weighted data, and that's also discussed in the BRFSS documentation. Ensure that all appropriate states are represented if you're doing multi-state analysis. It's not as important if you're doing a single state analysis, if you're interested only in one particular state. And again, feel free to reach out to us if you have any questions. Next slide. And so that ends my portion. And so our next presenter is Dr. Aaron Bolden. Dr. Bolden is an assistant professor in the Department of Health and Exercise Science at Appalachian State University in Boone, North Carolina, and an analyst here with us at CDC's Alzheimer's Disease and Healthy Aging program. And Dr. Bolden will be describing the BRFSS Caregiver Module. Thank you.
Thank you, Dr. Taylor. And I just wanted to mention quickly before I jump in that we are focusing in this portion on caregiving, and really this is referring primarily to informal caregiving, so people who are providing care for family members or friends in the community, and we'll go into more detail about exactly what the definition is in just a moment. Thanks, Michael, for pulling up this slide. You can go ahead and advance to the next one, please. So I just wanted to start with a brief overview of everything that is in the caregiver module, and then we'll walk through the specific items. So first, there are people that we classify as caregivers, which I'll define in just a moment. But among those people who say yes, that they are caregivers, people that we classify as caregivers, they're then asked a number of things about the kind of care that they provide, and also a little bit about the person for whom they provide that care. So we collect information about the relationship between the caregiver and care recipient, the duration, so how long the caregiver has been providing care, how many hours per week they typically provide care, what the care recipient's major health problem or disability is, and then whether the caregiver provides help managing personal care, and whether or not they provide help with household tasks. And finally, we ask them to identify one support service that they most need. I also want to mention that along with identifying current caregivers through the BRFSS, which is the primary aim of this module, we actually do ask people who aren't currently caregivers whether they expect to provide care in the next 2 years. So I'll come back to that as well. Next slide, please. So here is what we call the caregiver screening question. This is how we identify caregivers in the BRFSS. There's a short lead-in and then the respondent, and it's asked during the past 30 days, did you provide regular care or assistance to a friend or family member who has a health problem or disability? So that's our definition of a caregiver in the BRFSS, asking just about in the past month if they provide care or not, if that care is regular, and then if they're providing it to someone who has either a health problem or a disability. So if a respondent says yes to that question, they're considered a caregiver and they get asked the subsequent module question that I'll be walking through. If they say no to that question, they're considered to be a non-caregiver. And the next response option I have listed here is not actually a response on the survey, but if someone says they're a caregiver but they report to the interviewer that that care recipient died within the past month, the interviewer tells them that they're sorry to hear of their loss and then goes on to the next module. So those people, while you may be interested in understanding how many people have recently been caregivers, they're not asked the subsequent module questions. And so largely for that reason, we classify them as non-caregivers. So we don't have any other information about who that care recipient was or what kind of care they were providing before that person died. I also do want to mention here that Chris mentioned the subjective cognitive decline module is only asked of people age 45 and older, and the caregiver module is different. So it is asked of all respondents to the BRFSS, so that would be anyone age 18 or older, and they could be providing care to anyone of any age. So we could be capturing, for example, parents who are caring for a child with a disability, or we could be capturing caregivers who themselves are older and are providing care for a spouse, for example. Next slide, please. So as I mentioned before, people who say that they are not currently caregivers, or people who said they didn't know or weren't sure on that caregiver screening question or who just didn't answer it at all, are asked in the next 2 years, do you expect to provide care or assistance to a friend or family member who has a health problem or disability? And so this is just trying to project a bit to see not only who is currently providing care, but who thinks that they will be providing care in the future. So this can be useful for states for planning purposes, or just to get a sense of what people's expectations are around care in the future. Next slide, please. So the next kind of category of questions in the caregiver module, once we've identified someone as a caregiver, they're asked a little bit about the care recipient. So the caregiver is asked to report what is his or her relationship to you. For example, is he or she your mother? And if the caregiver reports they provide care for more than one person, the interviewer prompts them to just think about the person who they're providing the most care to for the rest of the module. We don't actually capture if people are providing care for more than one person. We just collect the information about that single person for whom they provide the most care. So for this relationship question, there are actually 15 different response options. So mother, father are examples. We also ask about people who have a same-sex partner that they're providing care for. We can distinguish parents-in-law from parents. We also have response options that include grandmother and grandchild. And finally, there's an option for another kind of relative and also non-relative. So you can distinguish family from non-family caregiving in the BRFSS data set. The second care recipient characteristic that is asked about in the BRFSS is the care recipient's main health problem, long-term illness, or disability. And so, again, this is all reported by the caregiver, so it's their perception of what the most important health problem is for that person. And there are 12 different conditions that are response options. The interviewer does not read them. They just code based on what the caregiver reports is the major health condition. And so these range from chronic conditions to mental illness, substance abuse, and then there's also an other category, which actually tends to be relatively large. As much as 40% of respondents have the health condition classified as other. In a part to address that fact, in 2016, there were 2 new response options added for this question. So one is injuries, including broken bones, and the other response option is just old age or infirmity or frailty, because we saw that a number of respondents were just saying that they're getting older, and that was the reason that they were providing care. Next slide, please. So next, we asked the caregiver to report how long they've been providing care and then how often they provide care for this person. So the duration question is, for how long have you provided care for that person? Would you say less than 30 days, 1 month to less than 6 months, 6 months to less than 2 years, 2 years to less than 5 years, and more than 5 years? So this is not collected in a continuous fashion. These are the response options that caregivers are given. So we would just record, excuse me, we would just record their response for that. Likewise, for the amount of caregiving per week, the question is in an average week, how many hours do you provide care or assistance? Would you say up to 8 hours per week, 9 to 19 hours per week, 20 to 39 hours per week, or 40 hours or more? So again, we don't collect it on a continuous basis, just in these categories, which were designed to reflect essentially working hours. So you could think about whether someone is providing, part-time or full-time equivalent care for someone. Next slide, please. And then we ask caregivers to report whether or not they provide specific categories of care. So the first one you could think of as activities of daily living kind of care, ADL type activities. So the question is, in the past 30 days, did you provide care for this person by managing personal care, such as giving medications, feeding, dressing, or bathing? And the second question is, in the past 30 days, did you provide care for this person by helping with household tasks such as managing money, giving medications, managing money, or preparing meals? So each of those is a yes-no response. So caregivers could say yes to both, yes to either one, or no to both of them. And just to give you a little bit of a sense of how frequently caregivers report these, just over half, so about 55% of caregivers say they help with ADL type activities, so the first one listed on the slide, and about 80% of caregivers report that they help with IADL types of tasks. So this is an example of a question that you could, report the percentages of caregivers in your state or across the U.S. who do these types of tasks, but you also might consider perhaps you want to define caregiving based on not only that first question, but also on one of these. So perhaps you would only consider people caregivers if they at least provide IADL types of activities. Next slide, please. The last question that current caregivers are asked is, of the following support services, which one do you most need that you are not currently getting? So the response options are listed here. So classes about giving care, help in getting access to services, support groups, individual counseling, respite care, and I don't need any of these is essentially a response option as well. The majority of respondents actually say they don't need any of these support services. So I just want to mention, and by majority I mean about 80% in 2015 and 2016 said they didn't need any of these support services. So I just want to point out a few caveats about that. First is, we have a specific list of support services, so perhaps they need something that's not listed here. The other option is that they may be getting the services that they need already, so they just don't have an unmet need for services. So this is only seeking to identify unmet needs among caregivers, not the activities or the services that they're currently using. We don't have a way to capture that in this data set. Next slide, please. So when analyzing the caregiver module data, everything that Valerie and Chris have already mentioned comes up again here. So I just want to mention that you can calculate the frequency of caregiving. You could also look at the health characteristics of caregivers in addition to looking at the kinds of care that they provide. I'll present a few results here momentarily, and all of them are just looking at weighted proportions and using chi-square tests to see if one percentage is different than another. I'm in the interest of time, I'm not doing the next bullet today, but I did just want to mention, you'll see that there are differences in age and sex between caregivers and non-caregivers. So one thing you may want to do if you're analyzing these data is to adjust for age and sex. One way to do that is using a regression model. And I just tend to like this log binomial regression model, which estimates the prevalence ratio rather than an odds ratio, which some researchers have shown is a better fit for these kinds of cross-sectional data like we have with the BRFSS. So there's a reference there at the bottom of the screen for an article by Barros and Hirokata that describes differences between different modeling approaches, and I'd be happy to provide some data code or more details if you're interested. So all of the estimates that I'll be presenting next are weighted, as Chris and Valerie have both talked about. That weighting is critical to accurately reflect the population from which the respondents are sampled. And they're also based on the version of the questionnaire that the caregiver module appeared on. So that's, as Chris said before, you can go on the BRFSS website and see a list of which versions included which modules in which states. And so you just apply the appropriate weight based on that. Next slide, please. So the data that I'm presenting here combines the 2015 and 2016 BRFSS caregiver module states, not quite as large as the cognitive decline module was during these 2 years, but 38 states, the District of Columbia and Puerto Rico, included the caregiver module in one of those years. And I just want to note, some states, the 5 listed there, included the module in both years. And so when that happened, we just used the most recent year of data. There is another approach. If you wanted to include both years, you would just need to adjust the weights to represent the proportion of respondents in each year. I have a brief example of how you could do that on the slide here, but as Chris has said, you're welcome to contact us if you have questions, if you want to do that yourself. Next slide, please. So across the 2015 and 2016 years, there were over 232,000 respondents in those 38 states, DC and Puerto Rico, who responded to the caregiver module, and that's an unweighted number of respondents. And almost 50,000 of those respondents were classified as caregivers. When you weight those numbers, that translates to just over 20% of adults age 18 and older being caregivers in these states and territories. So 1 in 5 people, 1 in 5 adults is providing care to someone with a long-term illness or disability. And then among the non-caregivers who were asked the follow-up question about providing care in the next 2 years, 16.7%, so nearly 1 in 5, said they expected to start providing care in the next 2 years. So you can see that from a public health perspective, this is a substantial proportion of the population and is really a critical component of community supports and long-term care in the U.S. Next slide, please. So this slide just shows you by state or territory what percent of adults reported providing care. And it ranges, again, the average was 20.6% across all the states, It ranges from a low of 13.7% in Puerto Rico to a high of 28%. Sorry, I can't actually see that on my my screen right now, in Tennessee. Excuse me. And in general, this isn't true across the board, but in general, states in the South where the prevalence of chronic disease is higher also tended to have a higher prevalence of caregiving. Next slide, please. And I just wanted to give an example. This is one way that you can use BRFSS data. You could compare caregivers and non-caregivers, as I've done here, using the core questions. So age, sex, health status, and chronic conditions are all on the core part of the BRFSS. So that means they'll be available along with the caregiver module in any state. So you can look at things like, are caregivers different than non-caregivers on demographic characteristics and on health behaviors. Here on this slide, they actually are significantly different using just the chi-square test. Comparing the two, caregivers are more likely to be women. They tend to be a little bit older than non-caregivers. And they also tend to report poorer general health, more frequent mental distress, which is defined as experiencing 14 days or more of poor mental health in the past month. And they're also more likely to have at least one chronic health condition. Next slide, please. And employment status is another question that's on the core of the BRFSS. So if you were interested, you could look at whether or not caregivers were employed. You could also, specifically focus on caregivers who are employed and compare them to caregivers who aren't, for example. You can see from the 2015-2016 data, just over half of caregivers work outside of the home, so 55% were employed, almost 20% were retired, and then kind of a smattering of caregivers are not working or unable to work, homemakers and students. Next slide, please. And then this next figure reiterates some of the data that we saw in the earlier table, and again compares caregivers and non-caregivers on general health status, frequent mental distress, and this also adds frequent physical distress, which is having 14 or more days of poor physical health in the past month. And again, just another way to illustrate that there are differences between caregivers and non-caregivers. And this is not age and sex adjusted, but based on the earlier table, we know there are age and sex differences, so you may want to account for those when you do these kinds of analyses. Next slide, please. So that's just a short summary of the caregiver module and a few quick examples of what you could do with the data. So with that, I will turn it back over to Dr. Taylor.
Thank you very much. And our final presenter for today is Karen Wooten. Karen is a statistician and data manager with CDC's Alzheimer's Disease and Healthy Aging program, and she will be presenting on the CDC Healthy Aging Data Portal. Karen.
Thank you, Dr. Taylor. The Healthy Aging, back one. Okay, sorry. Okay, the Healthy Aging Data Portal is a great source for the latest estimates on a range of key topics concerning older adults. My plan today is to walk you through some of the features of the data portal, which I hope will encourage you to use the portal for your data needs for adults 50 years of age and older. Next slide, please. The portal has estimates on select factors for older adults and caregiving and cognitive decline, as well as mental health, nutrition, physical activity and obesity, overall health, select screenings and vaccines, smoking, and adult and alcohol use. All estimates in the data portal were derived from data collected by the Behavior Risk Factor Surveillance System. Next slide. Please go to the BRFSS website for more information about the sample design and to get the complete list of the limitations on the use of these data. Estimates reported in the Healthy Aging Data Portal were assessed through for reliability and those that do not meet standards for inclusion are excluded and reported as data not available in the graphics and tables. Next slide, please. The link for the Healthy Aging Data Portal is www.cdc.gov/aging/index.html. But the portal can be Googled on the internet using the words Healthy Aging Data Portal. Next slide, please. The portal is an interactive data visualization product using Logi Analytic software system. It offers two ways for accessing estimates for older adults. These are available at the click of a button using the Explore Healthy Aging Data by Location option or the Explore Healthy Data by Indicator option. Next slide, please. Before I walk you through these two options, I'd like to mention, I'm sorry, could you go back one? Okay. I'd like to mention the link that's circled in red on this slide. If you click on the link, Healthy Aging Data Portal, under the Create Custom Reports and Visualizations captions on this page. Okay, now we go to the next slide. This will take you to the chronicdata.cdc.gov website, where many data sources sponsored by the National Center for Chronic Disease Prevention and Health Promotion can be found, including the Behavior Risk Factor Surveillance System, the 500 Cities Project, and Chronic Disease Indicators. Both of these systems use the BRFSS data as their data source. There are a few pre-programmed graphics available here, although we're still working on updating those to reflect the latest available estimates. There are also options to download the Healthy Aging data set. Data for all of the projects on the chronicdata.cdc.gov website may also be downloaded. The back arrow, however, at the top of the page will take you back to the Healthy Aging homepage. Next slide, please. Okay, now that we're back at the Healthy Aging homepage, I want to walk you through how to access first the Explore Healthy Aging Data by Indicator module. Clicking on the drop-down menu bar will give you the list of categories in the data set. Then a click on the Go button will take you to the actual module. Next slide, please. In this example, I selected the Caregiving category, clicked the Go button, which then took me to this screen. Once the category is selected from the home page, the module will show the category that you selected, and the next data need is the data collection year. At any time, the category of interest and the data collection year can be changed. For most of the 40 indicators in the data portal, estimates are available for years 2011 through 2016. But the Caregiving and the Cognitive Decline modules report data for 2015 and 16, with the exception of a couple of the indicators for cognitive decline that are also reported for 2011 for some states. Next slide, please. The Explore by Indicator module displays estimates in map format as the default. Also, its default is the first indicator in the drop-down indicator box, and defaults to the first age group listed in the age drop-down menu box. On each page, the user has three options to select the indicator of interest, the data collection year, and the age group. Next slide, please. This example shows the age groups that are available in the portal: age 50 to 54 years, 55 to 59, 60 through 64 and ages 65 years or older. If no age group is selected, as I mentioned earlier, the default is to display estimates for adults ages 50 to 54, which is the first age group in the drop-down menu box. Next slide, please. This example shows, here I want to direct your attention to the widget circle in red. The map is the default display, but you can also get these data in bar graph format and in table format. Next slide, please. This is an example of the data display in bar graph format. Next slide, please. And this is an example of the data displayed in table format. And the next slide. At any time, the user can link to the home page to choose a different data display option. These options are located at the top of each page. In this example, I'm going to choose the home page link to go to the next option, which is the Explore by Location module. Next slide, please. Okay, the Explore Healthy Aging by Location module. This module produces bar graphs or tables for each indicator in a given category. The location of interest must be selected here, either by clicking on the state's shape on the map, or, next slide, or clicking on the drop-down menu box and selecting the location of interest from this menu. Next slide. After the location has been selected, as in the previous screen, the module will show the location that you've chosen and will prompt the user to select a category of interest and the data collection year. Next slide. This is an example of the Explore by Location display module. The default display is in bar graph format, but at any time the user can change to the table format. Each panel represents a different indicator within the selected category. Here I've chosen to display one panel in a table format rather than the default bar graph format. Next slide, please. It's easy to switch to produce graphs and tables for different locations, different categories, different years in the Explore by Location module. Simply click on the drop-down menu for each and make your choice. Next slide, please. In this example, I changed the category to screenings and vaccines and selected most recent for the data collection year. When the most recent data collection year option is selected, the latest available data for any given category or indicator will be displayed. In this example, the first panel reports data for the 2016 data collection year, but the second panel reports data for the 2015 data collection year. In this example, data for high blood pressure were not available in 2016. Therefore, the most recent data available were presented in the panel, which for this indicator is 2015. Next slide, please. Okay, wrapping up. You can always go to the home page by clicking on the home button at the top of any of the pages in the Healthy Aging Data Portal. Next slide. So we certainly hope that you will find this tool a valuable resource For the latest estimates from the Behavioral Risk Factor Surveillance System for adults ages 50 years of age and older, the Healthy Aging Data Portal is updated annually with the latest available estimates from the BRFS. Next slide. Okay. Should you have any questions or concerns about healthy aging in general, or the data portal, or any of the data sources in the chronicdata.cdc.gov website, please contact the CDC info at 1-800-232-4636. Thank you.
Thank you, Karen. And thank you to all of our presenters today. We will now open the webinar for questions. Michael?
Hey, thanks, Dr. Taylor. Great job, everybody. At this time, I want to make 2 points. I'm getting a lot of questions about the slides on the chat. And as we said in the beginning, some of you may have come on late. They will be archived, and you will be notified when they're ready for public viewing. So just be looking out for that. We're archiving the slides. And then the second thing is, as you ask questions, I've got some on the chat, and I've got one person with their hand raised. If you could just say who you are, which organization you're representing, who you'd like to address your question, and then go ahead with your question. So without further ado, let's see here. Rosalind Griffin, go ahead. The mic is open.
Yes, I had just a question and a comment with respect to the explanation when the caregivers indicated that they didn't need any of the options that were selected. I'm in private practice, and I would like to suggest from my practice experience, I work with a number of adults who happen to be caregivers. And some of them have made promises to the person, particularly if it's a close relative, mother, father, that they will do the caregiving. And they have these relatives indicate to them that I will not have anybody besides you do my caregiving. So these individuals come to me under stress because this is beginning to affect their mental health and their physical health. So what I'm suggesting here is that they answer this question in this way, which really may not reflect the emotional and physical stress that they're under, but they feel guilty and cannot lose the confidence of the person for whom they're caring. So they reject outside intervention, if you understand what I'm saying. And I wonder if that's been thought about.
Hi, Rosalind. This is Dr. Lisa McGuire. I lead the Alzheimer's Disease and Healthy Aging program at CDC. And thank you for your comments and sharing your experiences with us. That question asks specifically if they need specific types of services, such as respite care and some other services. Unfortunately, one of the things we did not ask in this survey is we don't know what kind of services they're already receiving. So yes, a majority of them say they don't need any of the services we're asking about, but we don't know why they don't need them. It may be because they're already getting services, or it may be that the services are not available in their area, or they just don't know what those kind of services are. So definitely hear what you're saying and recognize that I think this is a limitation of this data source, what we're seeing here. But definitely we know when it comes to caregiving that a person's mental health can be compromised because of the caregiving situation, because it can be very time-consuming, intensive, and it can have a spillover effect into the rest of that person's life. So thank you very much for that question. Michael, do we have other questions?
Yes, ma'am. Thank you, Dr. McGuire. We've got one on the chat from Adam Leisure. How can folks with cognitive impairment possibly answer such detailed questions accurately? Plus, has anyone looked to ask folks with confirmed cognitive issues the same questions? End of question. Ready for response.
Thank you, Michael. This is Chris Taylor. This question has been brought up before. What these questions try to get at is a very mild type of cognitive impairment. And you can see from some of the answers, someone could report or self-report that they're having an increase in confusion or memory loss, and they may or may not be changing their lifestyle as a result of it. As people go through the BRFSS questionnaire, if the interviewers who are very well trained are trained to understand and end an interview if they believe someone's not providing accurate information, or if it's not someone that can be interviewed in a way that provides reliable data. So the questions we're asking about for cognitive decline ask about a very mild impairment. It's not something we believe would jeopardize their responses as much as what interviewing behavior might already be detected as they go through the behavioral risk factor surveillance system questions.
All right. Thank you, Doctor. We've got one more question on the line. It's an email, mercedeszm1@gmail.com. Your mic is open. Go ahead with your question.
Hope you can. Now, my question is I'm trying to find out, if you guys measure the post effects of the survey after treatment, and I'm trying to find out how it is possible to be able to use this in private practice, to follow patients from pre-exposures to outcome levels. And that's what I'm trying to find out. And I'm glad to hear that another provider is here, I'm using the system as well. I am in Douglasville, Georgia.
Thank you. So this is, again, Chris Taylor. So the BRFSS is designed to assess behaviors and risk factors associated with health. So it's not designed to provide clinical recommendations. It's a data gathering tool. And so the data assessed is used by many programs at CDC, as well as at state health departments and academic institutions, to write guidelines and recommendations that can then be incorporated into clinical practice. But the survey itself really is not an interventional tool. It shouldn't be designed to take the place of practice. It's a way for public health practitioners, including academics and people in state health departments, to really know what's going on in their state, so they can direct actions and take actions to really start to improve the health of all populations.
Okay. Thank you, Dr. Taylor. We've got a question on the chat from E. Spalding, and this is concerning race and ethnicity. There may be a tendency to be leery of truthfully sharing this information because it may be used to the detriment of that individual's race or ethnicity in some way. Is there a method to assess the respondent's level of trust of the use of their race, ethnic information, or if they are answering truthfully? End of question.
This is Chris Taylor. I guess I would say the data that is collected, there are no names that are collected. This data is collected anonymously. It's reported without identifiers in a blinded data set. And a lot of steps are taken to ensure that nothing in it is identifiable of everyone. Specifically, there is no question there asking about trust, but we know there are a lot of steps taken that are written into guidelines across the federal government, that these data are protected and released in a way to ensure the confidentiality of all participants.
All right. Thank you, Dr. Taylor. Again, the floor is open. Are there any other questions? And again, you need to use the raise your hand feature, which is on the right-hand side of your screen, should be. If you click that button, I can pick you up and open your mic. Okay, there's an E. Spalding with a question. E. Spalding, go ahead.
I'm just going to take a moment to. I'm taking a moment to mute my phone. I've been following on my phone. My name is Earthy Spalding. I'm a registered nurse, and I would like to follow up on the question that was just answered that I submitted. And my thinking is the perspective of the person who's answering the question, as opposed to the guidelines and everything that's been set up by CDC to protect anonymity and to protect confidentiality in the mind of the person who's answering the question. The information they're submitting could be used against people who are ethnically, racially like them. Has that been considered? End of question.
This is Chris Taylor. I guess I would say that the analysis we do, the looking at health risk behaviors, is designed to ensure that populations are identified to ensure that if they have health needs or at more risk for health behaviors, that those populations can be targeted for interventions that would help them at a public health level. Again, people who are in the BRFSS voluntarily participate. It's not a required process. And so they're also free to participate or not participate, or provide information or not as they see fit. They're free to refuse to answer any question within the data set that they would like, if there is any personal discomfort associated with providing information. But I believe the questions, the BRFSS is designed to help improve the health of the U.S., and that's certainly what we have used it for. As far as the perspective of the participants, we can't speak to that.
Okay, thank you, Dr. Taylor. Ms. Spalding, if you could, there's another question you submitted about caregiving. If you could just, I don't quite understand the question. If you could go ahead with that question, please.
I submitted that question when the speaker was talking about caregiving, and I'm trying to go back and see.
Okay.
Oh, I was asking if the question referred to caregivers who are being employed and paid as caregivers, as opposed to caregivers who are family members or friends who are doing it without being paid.
Okay, excellent. Thank you.
And this is Erin Bolden. I think that's a great question. And we don't specifically ask. So the short answer is we don't know, excuse me, whether they're being paid or not. But in general, we believe this is more informal caregiving. So generally family members and friends who are not being paid. In a previous version of the module, we did ask specifically whether or not people were being paid for the caregiving services. And the vast majority, I think 90% or more, of respondents said no. So I think that is probably still the case. It's possible that, they may be getting reimbursed through either a health insurance program or a local service or program. But because the question specifically asks if people are caring for family members or friends, we think we're capturing primarily informal caregiving. So people who likely are not paid for their services. But again, we don't specifically ask.
Okay, thank you. Great segue. I've got another question on the chat that has to do with caregiving. This is from Nancy Berkheimer. Is there any previous information about the differences between residential caregiving, caregiver and person receiving caregiving living in the same household versus the non-residential caregiving? Does this correspond to the intensity scale measured in hours? Is there a suggested cutoff for intense versus less intense caregiving situations? End of question.
So this is Erin again. Great questions. First, we also do not ask whether the person is living in the same household as if the caregiver and care recipient are living in the same household or not. That was also on a previous version of the module, but not on the current one, and I actually don't recall what the distribution looked like. So certainly this is a mixture of people who do and do not live in the same household. And the second question was about the relationship to duration, frequency. So again, we're not able to distinguish that using the current module. We did, in an earlier version, look at whether the hours of care and type of care provided might match up with a burden measure of caregiving. Those of you who work in the field may be familiar with the handful of caregiving burden questionnaires that exist and are sometimes used in clinical practice. And we actually didn't find a great alignment between the questions here and the questions on a standard kind of burden assessment. So basically, we often collapse categories. So we look at, for example, caregivers who provide 20 or more hours of care per week or 40 or more hours of care per week, but we don't have a specific recommendation on what would be considered high intensity. But that's something that certainly people could explore on their own, or again, if you wanted to perhaps use the ADL kinds of caregiving activities, you might think that would represent a more intense kind of care, or looking at that frequency and duration.
Okay, thank you. One more question from the chat. How can folks with cognitive impairment possibly answer such detailed questions accurately? Plus, has anyone looked to ask folks with confirmed cognitive issues the same questions? End of question.
A similar question was asked earlier that I addressed, because we ask about mild cognitive impairment. It's not the same as someone who would have memory issues that would impede their participation in the survey. And in terms of the second part of the question, that's not something we've looked at to compare the two groups. We certainly wouldn't be able to. It's not a possibility to look at people as part of BRFSS that are more cognitively impaired, because you would have to provide consent to participate in the BRFSS, and that's something that could not be easily obtained with someone who had severe cognitive decline.
Okay, thank you. We've got time for one more question on the line, and it's the Mercedes at Gmail, which has spoken before. Your mic is open.
Oh, I am so sorry. I've already asked my question.
Okay. No problem. So we've got time for one more. Rosalind, did you have your hand raised again? Okay,
yes,
go ahead.
I just wanted to speak again with regard to the person that talked about influence of ethnicity and responding in terms of suspicion, for lack of a better word, of what the research is about. I do think that this may be a limitation of the study in terms of the fact that these individuals are not likely to express to the interviewer that they have some concern. But this might be a limitation in terms of working with some ethnicities in terms of responding socially acceptable responses, but may not necessarily be as on the mark as you might want it to be. I think the study is valuable, but I do think that this may be a limitation.
Thank you very much.
Thank you for your comment. Okay, Dr. Taylor, did you have any final comments to address the group? We're winding down.
Thank you. I just wanted to thank my fellow presenters and also thank all of our attendees today for this webinar. Thank you for having an interest in older adult health, and thank you all for your wonderful questions and comments. In addition to my fellow presenters, I'd also like to thank Michael Jackson, our communication specialist, for his much appreciated assistance with the technical aspects of this webinar. And with that, we'll close. Thank you again, and have a great day.
Thanks, everybody. This concludes the webinar.